Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. I am going to discuss with you Internal Medicine 3.1 Competency Based Medical Education. The topic is Define, Discuss, Describe and Distinguish Community Acquired Pneumonia, Nosocomial Pneumonia, and Aspiration Pneumonia. Community acquired pneumonia, otherwise called CAP, nosocomial pneumonia, and aspiration pneumonia are three distinct types of pneumonia. This is William Osler who said this is now the captain of men of death. So this indicates the relevance and importance of pneumonia. Let us see what is pneumonia. The term pneumonia came from Latin. Pneumon means lung. Pneumonia is an inflammatory condition of the lung characterized by inflammation of the parenchyma of the lung, that is alveoli is inflamed with filling of airspace with fluid and is called consolidation. That is, the alveoli is solidified due to exudation of fluid in the alveoli. So basically pneumonia is an inflammatory condition of the alveoli with filling of the airspace with fluid or consolidation. There are different stages: stage of congestion, red hepatization, gray hepatization, and resolution, about which you will study in pathology. Let us go into definitions of various types of pneumonia. The most important thing is community acquired pneumonia. Second is hospital acquired pneumonia, otherwise called HAP. Third is ventilator associated pneumonia, otherwise VAP, and healthcare associated pneumonia, HCAP. Community acquired pneumonia is anyone developing features of pneumonia, that is cough, fever, sputum production, plus X-ray showing infiltrate, and patient is coming from the community. So it should occur within 48 hours of admission to the hospital. Whereas hospital acquired pneumonia means the pneumonia occurring 48 hours after admission. This is to exclude incubating illnesses. So hospital acquired pneumonia is a pneumonia occurring in a patient who is admitted and the duration of admission more than 48 hours. Ventilator associated pneumonia usually is defined as pneumonia occurring 48 hours after intubation. The new terminology is healthcare associated pneumonia, or HCAP. Here the pneumonia develops within 48 hours of admission in a patient who has hospitalization or institutionalization in an acute care hospital for more than 2 days in the past 90 days. That is, the patient may be coming from community, but the patient had been admitted for more than 2 days during the last 90 days in a hospital. Or he is a resident of the long-term care facility or nursing home. Patient with chronic dialysis within the last 30 days. So somebody is a patient on dialysis coming with pneumonia. This can be considered as a hospital or not hospital, healthcare associated pneumonia. Patient is on home IV therapy, home wound care for the last 30 days, patient on chemotherapy, or a family member with MDR pathogens. All these can be considered as healthcare associated pneumonia. Basically, remember community acquired pneumonia, hospital acquired pneumonia, and ventilator associated pneumonia. Hospital acquired pneumonia means pneumonia occurring 48 hours after admission to the hospital. Hope this point is clear to you. Now going to community acquired pneumonia, the definition I have already said is refers to pneumonia that develops in individuals who have not been hospitalized or residing in a long-term care facility or nursing home. And the pneumonia should be within 48 hours of admission. or the chest X-ray finding should occur within 48 hours. This is produced typically by certain bacteria, especially Streptococcus pneumonia. The majority of cases are due to this Streptococcus pneumonia, Haemophilus influenza, Mycoplasma, or viruses such as influenza or respiratory syncytial virus. The presentation is typical: fever, cough, breathlessness, chest pain. Sometimes there can be hemoptysis. In case of pneumococcal pneumonia, you can get a rusty sputum. And some patients may be sick and may need hospitalization. So the distinguishing feature is that CAP occurs outside hospital healthcare facilities, and the causative organisms are typically encountered in the community rather than that are present in the hospital. So let us look into what are the typical presentation of a patient with pneumonia. Usually they come with a high grade fever with rigor and chills. It is described as a bolt from the blue, that is sudden appearance of fever and rigor. So patient can have headache, loss appetite and mood swings. Patient will have lung findings, that is it is alveolar inflammation. So there will be cough with sputum production. The sputum, I have already said, in Streptococcus pneumonia, it is a typical rusty sputum. The pleura may be inflamed and it can produce a pleuritic chest pain. Patient can have aches and pains. They may come with vascular collapse. Hypotension may be the presentation. It may affect the central nervous system, can have headache and may come with a delirium. This is especially common in elderly. Sometimes there can be cardiac problems, already a patient has with heart failure or impending heart failure. Such patients, the precipitating factor for heart failure can be pneumonia. So they may come with breathlessness due to a cardiac, or it may appear as a cardiac problem. Nausea, vomiting can also occur. So these are the some. So there will be systemic symptoms related to the respiratory system, and sometimes they may present with the features of central nervous system, that is delirium or hypertension producing pre-syncope and syncope. As I already said, 50 to 70% of cases of community acquired pneumonia is by Streptococcus pneumonia, the most common. It is a gram-positive, it is produced by gram-positive diplococci, and the symptoms are typical. Textbook description: shaking, chills, fever, rusty sputum and pleuritic chest pain. And X-ray chest is the gold standard diagnosis, and lobar infiltrates will be there. So it produces what is called a lobar pneumonia. That is, the findings are confined to a particular lobe, upper lobe, middle lobe, lingual lobe, lower lobe, etc. That is why it is called lobar pneumonia. And there can be bacteremia in around 25% of the patients. As I already said, all patients with the suspected pneumonia will have an X-ray chest, and different patterns can occur. The typical pattern in community acquired pneumonia is lobar pattern. Particular lobe is affected, and organisms as already mentioned: pneumococci, Klebsiella, H. influenza. Sometimes patchy infiltrates can occur. This is especially common in viral pneumonia, atypical pneumonias. Interstitial pattern is seen in viral pneumonia, PCP, that is pneumocystis carni, now called Jerovici, legionellosis. Cavitatory lesions can occur especially in Klebsiella, tuberculosis, and sometimes you may get pneumatoceles and pneumothorax and Staph aureus. Some associated effusions can also occur in certain cases of pneumonias. This X-ray shows typical pattern of a consolidation. The lung is solidified. It looks like liver. So it is there is no air spaces because it is lung. The alveoli is filled with fluid. The details of the X-ray findings we will study at later stages. Now look at what are the risk factors for pneumonia. There are so many risk factors, but again remember smoking, underlying lung disease like bronchoasthma, COPD, immunocompetent, like HIV, use of alcohol, hematological conditions like sickle cell anemia, leukemia, any hematological condition, splenectomy. These are risk factors. Again, remember these associations. Asplenia or splenectomy leads on to Streptococcus pneumonia due to Streptococcus pneumonia or H. influenza. Alcoholic patients are prone for Streptococcus pneumonia, anaerobes in the mouth because they may aspirate, Acinetobacter and tuberculosis. COPD and smokers, H. influenza, Pseudomonas. Other organisms can occur. Klebsiella can occur in aspiration, and aspiration can produce multiple types of organisms. Oral anaerobes can occur. HIV, again, the whole community acquired pneumonia can occur. In addition, you may get atypical mycobacteria, Pneumocystis carni or the Jerovici. Somebody traveling in a cruise ship or in air-conditioned hotels, Legionella pneumonia can occur. Somebody with structural lung disease like bronchiectasis, Pseudomonas, remember, and Staph aureus can occur. So there are certain risk factors. There are certain bacteria which are pneumonias are characteristically associated. We should remember the term atypical pneumonia. So typically atypical pneumonias are produced by Mycoplasma, Chlamydia, Legionella, Coxiella burnetii, otherwise called Q fever, Chlamydia, that is cytocosis. Details we'll study later. Approximately 15% of community acquired pneumonias are atypical pneumonias. And atypical pneumonia, the typical symptoms may be absent, but the X-ray findings will be dramatic, and these pneumonias are sometimes called walking pneumonia. That means the patient, in spite of the significant radiological findings and features of pneumonia in the X-ray, the patient will be relatively asymptomatic, and that is why it is called walking pneumonia. And the treatment is different. The macrolides are the treatment of choice. Macrolides, tetracyclines. So this point to be kept when a patient comes with community pneumonia. Remember the atypical pneumonia. Now we go to the nosocomial pneumonia. Nosocomial pneumonia is also known as hospital acquired pneumonia. Pneumonia that develops 48 hours after admission to a hospital or healthcare facility. Why this 48 hours? This is in order to distinguish from the organisms that are incubating and developing pneumonia later. So that is why the 48-hour cutoff period. It is often caused by bacteria that are resistant to antibiotics. So you can get MRSA, that is methicillin resistant staph, Pseudomonas, Klebsiella pneumonia, etc. can be. So nosocomial pneumonia usually occurs in patients who are already hospitalized for other conditions, and most of them are immune suppression or weakened immune system. And it is a significant cause of morbidity and mortality in hospitalized patients. For example, somebody admitted for a surgical problem. They may be already having some immune suppression, diabetes, renal failure, etc. And if they develop pneumonia, this can be due to an organism in the hospital, and so they are resistant to antibiotics, and the treatment may not be very effective. The distinguishing feature I already mentioned, this occurs after hospital stay, often result of exposure to healthcare associated pathogens, and they are resistant to treatment with common antibiotics. Now we go to the next type of pneumonia, the aspiration pneumonia. Aspiration pneumonia occurs when foreign substances such as food, saliva, liquid or vomitus are inhaled in the lungs. Practically speaking, all pneumonias are due to microaspirations because these organisms are present, many of them are present in the pharynx and which are aspirated and can produce pneumonia. But here the aspiration is saliva, liquids, vomitus. So In which group of people it occurs? It commonly occurs in people with altered swallowing ability. That is a patient with altered level of consciousness, or drowsy patient, patients with a seizure, or a patient who is having stroke, Parkinson's disease, patient with dementia. So patients with neurological problems, swallowing difficulty due to mechanical obstruction to esophagus. For example, somebody has got a tracheoesophageal fistula, or a patient has got a carcinoma of the esophagus producing dysphagia, they can aspirate. So aspiration pneumonia, the importance is this is due to wide range of bacteria including oral flora, anaerobic bacteria, and there can be chemical pneumonia also because the aspirated content may contain acid, that is a gastric content may be aspirated. So there are different etiologies, multiple organisms and multiple etiology may be there. So the patient's history is important in the what is the setting in which the pneumonia occurred, that will help to differentiate this type of pneumonia. Now look at this patient. This is a 60-year-old male who is a smoker with diabetes mellitus, coming with a high-grade fever, resided chest pain, cough with rusty sputum for 1 week. What is your provisional diagnosis? So typically you can see that this patient has got features of pneumonia, that is fever, resided pleuritic type of chest pain and rusty sputum. So it is a patient has got a inflammation of the lung or inflammation of the alveoli. So what are the risk factors in this patient? One, the age of the patient, he is a smoker and has got a relatively weakened immune system because of the diabetes. So he has got a lot of risk factors. So has the patient been in a hospital? Has the patient been in a healthcare system? No. So this is a coming from a community. So I can say it is a community acquired pneumonia. What is the most likely organism? This is most likely due to pneumococci. But you should think about the atypical pneumonia also, but this sort of typical presentation is more in favor of a Streptococcus pneumoniae. So we have discussed today the various types of pneumonia, and overview of pneumonia has been presented. Hope it was useful. Thank you.